Welcome everybody to the next session, which is going to be on challenges of antimicrobial resistance in different scenarios. And this is going to be for 1 hour and a half with 3 different presentations. And it's my pleasure to introduce my co-chair, Dr. Regina Berba. She's currently professor at the University of Philippines and deputy director for health operations at the Philippine General Hospital. Dr. Berba has received multiple awards in the national and international agencies, and it's really a pleasure to be co-chairing with her.
Okay, so to start off, let's begin with our first lecture entitled Antimicrobial Resistance in Conflict Zones. Our lecturer would be Professor Souha Kanj. Professor Kanj is a professor of medicine at the American University of Beirut Medical Center, where she also serves as the head of the Division of Infectious Diseases, as well as the chair of the Infection Control Program, co-chair of the Antimicrobial Stewardship Program, and consulting professor at the Duke's University Medical Center. Dr. and Professor Kanj is a prolific author of over 320 peer-reviewed articles, book chapters, and up-to-date cards. So without further ado, let's please welcome Dr. and Professor Souha Kanj.
Thank you, Dr. Berba. And again, thank you for the organizers. It's really a pleasure to be here in beautiful Bangkok. And so I wish I would not have to present on a topic of AMR in conflict zones, but unfortunately, currently in the world, we have many, many areas under conflict, and sadly, it is contributing to the rising AMR. So this is the list of the disclosures, but none are related to the current topic. So I'm going to be covering mostly antimicrobial resistance in the Arab countries in the Middle East. This is where I'm from. I'm from Lebanon, a country in the Arab world in the Middle East. And I'll present some data on this, as well as data from Ukraine, which is the most also recent unfortunate war that we're experiencing. So before I talk about AMR in the Arab League countries, I just want to give you a little bit of a background. And this is a paper that we put together in 2018, and we were asked by the editor of Lancet ID to look at the epidemiology of common resistant bacterial pathogens in the countries of the Arab League. And while preparing for this review, I was really surprised to see that we didn't have a lot of good data published. There was a lot of differences in the studies published, variation among the countries in the availability of the antimicrobials, diagnostic technologies, and laboratory supplies. Nevertheless, with a lot of efforts, we were able to put together these color-coded maps. The darker the color, the higher the rates of resistance. And as you see, whether we look at gram-positive or gram-negative pathogens, there are countries that have very high rates of resistance, particularly carbapenem-resistant Acinetobacter baumannii, ESBL producers among Enterobacterales, and methicillin-resistant Staph aureus. But one surprising thing is also, even when you compare neighboring countries, the rates were very different from one to the other. And there are many challenges that exacerbate AMR in the Arab countries. You have outpatient antibiotic prescription that is not controlled. Patient self-medication is the rule. Lack of antimicrobial stewardship program in the majority of the hospitals in some countries. And in countries where you have good control and good stewardship, they receive patients as transfer from countries where ASP is lacking, and therefore transferring the resistant pathogens. And if we look at wars and displaced population in the Arab world. As you know, wars have played really a central part in shaping the modern history in the Arab countries. And the region has endured a lot of wars, colonial, anti-colonial, civil wars, and long-term conflicts. And since 2001, it is believed that the region has been one of the worst affected by wars. And this is a relatively recent map. If you look at the countries in the state of conflict and fragility in the WHO Eastern Mediterranean region, you see that there are countries that are classified as high institutional and social fragility. My country, Lebanon, is one of them. And then you have 9 countries that are classified as medium to high intensity conflict. So you can imagine the problem, how big it is. And in this editorial from Lancet, Davi wrote, AMR in the Middle East is a perfect storm because, as you can imagine, wherever you have wars and conflict, you have a lot of wounded patients, you have loss of laboratory facilities, you have displacement of refugees, and you have increasing pathogen exposures. All this will contribute to the emergence of resistance. So I'm going to give you examples from the war in Syria. And as you remember, the war started in 2011, 14 years ago. And the effects have been really devastating: malnutrition, collapsing sanitation. A lot of Syrian children died in the country, but also those who attempted to leave the country, also a lot of them died on the way. And as Worcestershire said, you have to understand that no one puts their children in a boat unless the water is safer than the land. And that gives you an image of how bad the situation was in Syria. But if we look at the displaced populations in the Middle East, it is estimated that more than 15 million internally displaced people in the Middle East as of 2022, 26% of the global numbers of IDPs, and it's thought to be the second highest concentration of IDPs, only following the sub-Saharan African region. And in the case of Syria, the refugees went to neighboring countries. The majority went to Turkey, Jordan, Iraq. But those going to Lebanon really constituted a major problem. So you have to realize that the influx of 1 million refugees would be massive in any country. So for Lebanon, the impact was really staggering. Lebanon is a very small nation, and it's currently estimated that 1/4 of the population of Lebanon is made of either Palestinian refugees or Syrian refugees. And the challenges for refugees in Lebanon are at many, many levels. You have healthcare challenges. A lot of people have no insurance coverage. With the Syrian war, this happened also in the close proximity to the economic collapse in Lebanon, really rendering a lot of people, Lebanese, but of course the refugees living in poverty. And one example, when you look at risk of diseases, for example, when we looked at data of COVID-19 infections, the Syrian refugees' mortality was 4 times more than the Lebanese population. And when you think about displaced populations and you think about the refugee camps, how the refugees live in, whether it's in Jordan, in Lebanon, in Gaza, or in Yemen, they all share similar factors: inadequate shelters, overcrowding, insufficient nutrient intake, poor vaccination, and last but not least, poor water sanitation. So in this report, Ula Abara looked at drivers of AMR within Syria, and there were many drivers pre-conflict and drivers during the conflict, and the consequences were really tremendous. But also we need to consider that we have inability to perform bacterial surveillance. So whatever data you find there is really not very accurate. And I'm going to share some examples that had been published. And in this also report that was published this year, also by Ulle Abara and colleagues, they looked at the linkage between conflict and antimicrobial resistance. And there are many things that play a role. You have the factors related to the direct conflict, you have the climate and disasters effect, you have the displacements and the demographic effect and instability, and you have the system fragility. All these play a major role to fuel antimicrobial resistance in this population. So also, I'd like to re-emphasize on the fact that we have very limited laboratory facilities in the settings of war and conflict, but also shortage of drugs and supply chain disruption. The drugs that come into these countries are suboptimal. There are no studies that look at bioavailability. A lot of different versions of the generic drugs, and no one is able to test whether these are good drugs or not good drugs. And also, in the midst of wars, I give the example of Lebanon here. You have direct targeting of healthcare facilities. This is only a few months within the most recent war on Lebanon. And if you look at the data on how many primary healthcare centers were completely destroyed, 96, and 5 hospitals were completely destroyed. So you can imagine how this will have an effect on the care of patients in general. And this is also another example from Gaza, where the majority of hospitals have been completely destroyed or rendered non-functional. Food shortage is another thing that we need to keep in mind, because as patients are as people are malnourished, they are much more prone to develop various infectious diseases, including fueling antimicrobial resistance. And obviously, lack of infection control practices and inappropriate usage of antibiotics. Now, when we talk about AMR, we cannot ignore the impact of the disruption of the WASH services. And this is the classic rules. In every war, there is significant destruction and contamination of water sources, very limited access to safe water and sanitation, also fueling many infectious diseases, including spread of infections with antimicrobial resistance. And in many of the wars, we see that the most vulnerable are the most affected, elderly people, children, or patients with comorbidities. This is from the Geneva Water Hub report that was published 2 years ago on how in Palestine the sewage and waters were mixing. And although people tend to worry about the presence, we need to worry about the future. Even when the war stops, when you have this mixage, the effect of AMR persistent in the land is going to be tremendous. So we can't talk about One Health without considering the long-term consequences. So in this report, Christelle Moussalli was trying to describe what's going on in Gaza, and she really wrote the sentence that what's happening now is beyond words, and it feels futile to mention antimicrobial resistance because people are so worried trying to survive. So like people were not paying attention to what can be done to prevent AMR. So let me give you, in terms of numbers, some of the data that has been published. And as I started to say, there isn't a lot, but we're going to try to make some sense out of what's already published. This is from a paper published in 2018 looking at antimicrobial resistance among migrants in Europe. And it was a systematic review and meta-analysis. And what they found is that among all migrants, 25% had any detected antimicrobial resistance carriage. And if we look at the dark blue, you look at MRSA in the overall refugees, but particularly high numbers from Syria, Afghanistan, and others. And this is from a paper published a couple of years ago looking at global displacement from conflict and the cross-border spread of AMR. And they took 3 examples, one from Ukraine, one from Afghanistan, and one from Syria. So if you look at the top of the figure here, and you look at the Klebsiella pneumonia resistance to carbapenem, 76%. Acinetobacter baumannii resistance, 73%. So these are pathogens that are a problem for the country itself, but they can also spread by travel to the other countries that receive such infected and colonized patients. This is from an old data from Syria because, as you can imagine, not a lot is published out of Syria. This is a study that looked at 2-year data on antimicrobial resistance from more injured patients from Syria, and the rates are alarming. 20% carbapenem resistant among E. coli. You know, when you look at data from the US now, when you have 2% carbapenem resistance among E. coli, 20% was present in Syria, and this is more than 10 years ago. Tigecycline resistance among Acinetobacter baumannii was 64%, but even colistin resistance among E. coli was reported to be 8%, and again, this was more than 10 years ago. And this, in this report, we look at AMR among the glass pathogens in the Middle East, and this was a systematic review, and again, the numbers are quite alarming. Carbapenem-resistant Acinetobacter baumannii, over 70%. MRSA rates, 45%, but strep pneumo non-susceptibility to penicillin is also very, very high, 50%. In Iraq, although this is a country that has been under a lot of wars and conflict, unfortunately, not a lot is published. This is a report that looked at heavy metal toxicity in armed conflict, and this was thought to potentiate AMR in Acinetobacter baumannii by selecting for antibiotic as well as heavy metal co-resistance mechanism. This type of research is undergoing at the American University of Beirut, where I'm working. And as you recall, initially Acinetobacter, when it became famous, it was called Iraqi bacter among the soldiers who returned from Iraq to the US. Data from Gaza from before the current war were also very alarming. In this report, it was found that 34% of bacterial contamination in hospital waters with very high resistance to carbapenem and cephalosporins. Can you imagine having that high of a contamination rate in your hospital environment? These are really very alarming rates. And in this report that was published by Médecins Sans Frontières, MSF, they looked at post-traumatic Pseudomonas aeruginosa osteomyelitis, and they collected isolates from 2 different populations of countries under war and conflict, Mosul from Iraq and from Gaza, and also reported alarming rate of more than 35% of their Pseudomonas aeruginosa had multi-drug resistance. But also, a lot of their patients had really polymicrobial infections. And among those that had Staph aureus, 95% were MRSA. I mean, again, these are very, very high and alarming numbers. This was published just this year, 2025, looking at AMR and war from the EMRO region and looking at data from 6 different countries. They collected data from 19 studies. And as we can expect, because they looked at injured, wound injuries, Staph aureus was the most common, followed by Pseudomonas aeruginosa and Acinetobacter baumannii. But also the resistance rates were very, very high. Again, more than 50% MRSA, carbapenem-resistant Acinetobacter baumannii, more than 60%, as well as more than 20% carbapenem-resistant Pseudomonas aeruginosa. So again, very high rates in these countries among injured. What about Ukraine? This is from last year, published by Guido Granata from WHO. And what they reported is very high rates of the New Delhi metallo-beta-lactamase producers among their patients. So again, you heard yesterday Dr. Patterson speaking about the lack of many effective drugs against NDM. And you can imagine even the new drugs that are on the market, they can't make it to countries under wars and conflicts because of the cost and the logistics. And this was published just a few weeks ago, looking at evolving antimicrobial resistance of extensively drug-resistant gram-negative severe infection from Ukraine. This is an observation study through a joint Ukraine-UK collaboration, and looking at the molecular data of the XDR gram-negative. And what they reported is a high prevalence of NDM and oxatype beta-lactamase genes, but also an increasing scope of alternative genes, including unusual finding of isolates that co-produced NDM and KPC Pseudomonas aeruginosa, as well as Acinetobacter baumannii. And in this slide, you see the type of carbapenemases that were produced by Enterobacterales, Acinetobacter, and Pseudomonas aeruginosa. So I really refer to this very recent review to look at the details of what's published. I think when we talk about AMR during wars and conflicts, we tend to focus more on bacterial infections, but we cannot forget that fungi also play a major role. This is from a recent review that we wrote on invasive fungal infections in wars, and really did not find a lot of published report, and most of the data comes from countries such as Iraq and Afghanistan, where people don't publish what they see as much as in the Western world. But we made it to this New York Times magazine. We reported a news reporter who was injured, and on the same day of admission, she had mucormycosis. We treated her very aggressively with surgery, liposomal amphotericin B, but she wasn't getting better. And she ended up having a co-infection with an Aspergillus flavus that was very resistant, including to liposomal amphotericin B. So we need to keep the fungal infections in mind. So what are some of the proposed solutions to tackling AMR in conflict zones? I think MSF has done a lot of work in this area. And the basic package for anyone who's working with MSF in conflict zone and want to try to put a control on AMR is to focus on infection control and prevention and antibiotic prescription practices. So we need better surveillance. I think I showed you some of the published data, but this is not enough. We need to think of better diagnostic stewardship in resource-limited areas, and we need better education of healthcare practitioners. So the proposed schematic infection control and prevention that MSF has proposed is teach it, check it, sell it, live it, and build it. And I know in a lot of MSF work, this is the infection control phenomena that they follow. Microbiology and surveillance, I think if we want to get good data, we need to be using good microbiology. And I think in wars and conflicts, obviously you cannot have very sophisticated molecular diagnostic techniques. We need to be thinking more and more of point of care testing. It gives short turnaround time. We need to think about what is available that gives us high sensitivity and specificity and reduce the time of diagnosis, which allows prompt antibiotic administration, but also prompt initiation of proper infection control practices whenever we identify multi-drug resistant pathogens. Training on laboratory practices, this is something you're going to hear from Professor Heiman Wertheim about this. He's been involved in some similar activities, and this is a collaboration. So this example here is between CDC and global partners from ESCMID, from APHL, and trying to help Ukraine to improve AMR detection by several steps, including supporting laboratory training, providing modern lab equipment, developing standardized procedures. I think if we want to control AMR, we need better wash in conflict setting. We need to ensure we have water supply that's clean, improve ways to improve sanitation and hygiene promotion. It's easier said than done. I think in conflict, this is going to be very, very difficult to accomplish, but we need to keep trying. Take better advantage of artificial intelligence for antibiogram analysis, and there are some tools that are possible nowadays. For example, the antibiogo that is used by MSF in various countries. It allows to take a picture on your iPhone or whichever phone you have, and then it can give you information on susceptibility, flag MDR for IPC intervention, and so on and so forth. But we need to improve antibiotic prescription practices. This is one example of Yemen, where MSF trained an individual, but then that individual went back to Yemen, and on return, they received remote coaching from specialists all the time. So this type of remote training can improve the antibiotic use and the infection control practices in countries where you cannot train many people. So you've heard about GARDP yesterday. I think it's important to keep in mind that there are many societies and organizations that are working on accelerating antibiotic access and stewardship. And in countries that cannot afford to buy the novel antibiotics, organizations such as GARDP are working in a hub and spoke model so that they can bring the drug when it's needed the most in areas that cannot afford to buy it. But we need also to think of innovative stewardship training and also a hub and spoke approach to training. So you identify a group of people in the country that is under wars and conflict, you develop their skill, and then in a model of train the trainer. So then these people can train other people in their individual countries. So I think such models have been proven to be very valuable. One thing that we need to keep in mind that refugees are without health records. So they move from one country to the other and they lose any health care records. And this is a cloud-based electronic health record that has been developed at my university in collaboration with the Global Health Institute to try to keep records of what infections the refugees have, what type of multi-drug resistant pathogens they are colonized with. So the key actors to help dealing with AMR in conflict zones and displaced populations really need many collaboration between government, between NGOs, between international organizations, but also with the local authorities. I think it's only when they work all together that we can control the long-lasting effect of AMR in these countries. And this is my last slides, which are the concluding remarks. I think AMR is really a huge problem in conflict zones, and there is a lot that should be done, starting with better surveillance, with education, with collaboration. And with that, I thank you for your attention, and I invite you to come to ICC 2026 in Manila on behalf of the International Society of Antimicrobial Chemotherapy. Thank you for your attention.
Thank you very much, and congratulations, Professor Souha, for such a comprehensive presentation of resistance data in very difficult situations. For you who came in a little bit later, this is actually a joint symposium of the ISAC and APCCMI. And ISAC is the International Society of Antimicrobial Chemotherapy, and actually Professor Souha is our president in the ISAC. So are there any questions? We have time for one or two questions. Yes, please. Can you approach the microphone?
A really nice talk. So I'm Canadian, and we accepted a large number of refugees from nearly most of the conflicts. One of the things I struggle with is that, as you said, they come with no travel records, and they do not even come with pre-immigration screening records. Do you know of any programs that, or any countries that are screening refugees as they're landing and collecting that as a database? Because Canada doesn't do that.
Right. So I think in European countries are much better at screening refugees than Arab countries. Unfortunately, because of the very limited resources in the Arab countries, money is spent somewhere else. But I suspect that in some European countries, Germany and others, they do have active screening of refugees. But the model I showed you with Sigili is once they are admitted to the refugee camps and they enroll in primary healthcare organizations, then this is where we start collecting their health data.
Okay, so maybe we could park your question first for maybe if we have more time at the end of the session, but we need to move on to the next speaker.
Thank you, Dr. Berba. And it's now my pleasure to introduce the next speaker, Professor Heiman Wertheim. Professor Wertheim is a professor in clinical microbiology and head of the clinical microbiology department at Radboud University Medical Center. He's also the chair of the Radboud Center of Infectious Diseases and Infectious Diseases Research. And he is past president of the Netherlands Society for Medical Microbiology. And importantly, he is the president-elect for the International Society of Antimicrobial Chemotherapy. So Heiman will talk to us about worsening AMR post-pandemic, the COVID experience with a question mark.
Exactly. So thank you, Souha, and the organizers for inviting me to speak about this. So indeed, I put a question mark on purpose. So there was not a question mark in the program. So maybe let's start by putting out the question here to the audience. So we really thought that the pandemic, the COVID pandemic, had substantial increase in AMR as a result. So if you think that's the case, please raise your hand. So, okay, he thought that it didn't have a substantial increase in AMR. Okay, so good to know. So it looks like maybe 50-50 more or less, and a lot of non-voting people. So let's see how COVID-19 and AMR bacteria are collaborating. So at the beginning of the pandemic, there was a lot of overuse of antibiotics, a lot of papers coming out. There's overuse of antibiotics. There's a risk of AMR, and some people are really talking about the crashing of antibiotic stewardship, sort of having this sort of dramatic wording about how COVID-19 will have a very bad impact on AMR, which of course is a very valid thing to say, but the question is, is it really as dramatic as people thought it would be? Because many things were happening during the COVID-19 pandemic. There's a lot of disruptions going on over the place. We had lockdowns. We also had export bans on antibiotics and other drugs that were really important for patient care, also for ICU and anesthesia. So it's not just about antibiotics, but also for diagnostics. We had plastic shortages, so people didn't have even pipette tips for diagnostics. So a lot of disruptions, particularly in the beginning, and at the end, we were able to innovate, become resilient, and try to deal with these things. And so also a lot of good lessons learned for the future. So we should also think about the good stuff happening, and particularly having a very rapid vaccine. So there was a lot of questions about, okay, where is the pandemic going to cause in the direction of the AMR levels? So is it going to be a delta increase? So you already had a rise generally worldwide of AMR, so it's not something new. So it was rising anyway everywhere, not completely true. Some countries in Europe, you see MRSA going down. I'll show you later. Is it going to be a substantial increase, like a big delta, or maybe moderate? Maybe it will stay the same because you had more infection control increase, maybe also less antibiotic use because it's less healthcare given, so it could also stay the same. But even maybe if a lot of good things were happening, it also could have gone down, if you think it really on a positive side. So it's really about, are there higher levels of AMR due to the pandemic because of more antibiotic use and poor IPC, considering maybe staffing issues and people not really well trained taking care of patients on the ICU, so you would expect an increase in your delta of a more rapid increase, but you can also expect probably lower AMR levels, so also less antibiotic use because less healthcare given. So is that really the case? Maybe also more IPC, we had distancing, more masking, more gowning, more gloving. So maybe also there you could see if that really works synergistically together, you could actually create a decrease in AMR. So did we see that happening? Or did it more or less stay the same between a certain bandwidth because there was a balance between indeed maybe more antibiotic use but also more IPC or vice versa? So these are sort of the things I want to take you through and sort of look how I looked at it by going through the literature and see what you think later on. And there are two levels to look at this. So you had AMR in COVID patients. So these patients were admitted to ICU often, not of course always, so you had mild disease, severe disease, ventilated for a long time, some people really admitted for a very long time, more chance of getting a nosocomial and drug-resistant infection. But you can also have the overall healthcare. If you look at the overall system, you had multiple patients not probably getting surgery, so potentially less surgical site infections. So you can look at it in a narrow way, only in COVID-19 patients, or what is it doing in a broad way? And I think generally we have to look at it in a broad way, in a general way, but of course it's good to look at both, and I will look at both in this talk. So what about overall antibiotic use during COVID times? So in generally, overall in a certain country in your healthcare system. So this is an example of Poland in a primary care setting. On the left-hand side, you see the COVID patients in the COVID time. Let me see if I can use a arrow. Yeah, you.
Point here, words on the screen.
Oh, aha, thank you. So besides, so what Poland said that actually the antibiotics decreased. And also what was very interesting, that was huge also telemedicine going on. So a huge increase in telemedicine and less admissions if you relate it also to the COVID patients. So it was quite interesting to see. Indeed, of course, there are always antibiotics being sold, but there was a not dramatic increase. And actually, they said in outpatient care was really that the antibiotics administered were decreased, and particularly beta-lactam antibiotics were the most popular antibiotics being prescribed if they were prescribed in the first place. So this is an example from a more overall 71 country data, looking at pharmaceutical sales data across the globe. And also here you said in the first few months, indeed, there was an increase. So you see a little peak. So here you, in the dashed line, you see the COVID cases. And then in the red line, that's where you see the antibiotic sales. And this is for cephalosporin. So you see maybe a little peak in the beginning, but actually a decrease. Similar for penicillins, macrolides, and tetracyclines. So for tetracyclines, less of an effect, but also a more or less a less popular drug. So COVID-19 also here showed on a global level that the sales actually went down for antibiotics for various classes. Also in the UK, also lower antibiotic use once lockdown. So these are the antibiotic sales for prescription rates for various age categories, from the very young to the very old, particularly the highest sales as expected in the elderly, where there's a lot of cases due to COVID and the more severe cases happening there. And in the red line in the middle, you see sort of the average, and this is where COVID started to kick in, and you see actually decline in the prescription rates in the females and in the males. So males on the left side, females on the right side. So what about COVID-19 specific cases? So what's happening there regarding antibiotic use? So we've been talking about overall use. So here there are some data on what was the early empiric antibiotic administration in COVID-19. So overall, in the beginning of the pandemic, there was an increase, but as we learned along the way, there's not so many co-infections, so probably we have to sort of tone down our antibiotic consumption, and actually were people doing across the globe. You see also it differs per region, but if you look at the odds ratio of getting early empiric antibiotic treatment was the highest in this region, in the Southeast Asian region, where it's still quite popular. But you do see over time that actually we turned better, and then the early antibiotic administration started to decrease once it was learned that the bacterial co-infection was actually quite low. Also, if you look at African countries, so there are a lot of guidelines that were advising to really give antibiotic very early if people were admitted with COVID-19, being either mild or severe. So also there, also in the African region, a lot of antibiotic use potentially happening, but very little data to show what was truly happening there. So this is a slide I was able to sort of borrow from Souha, but I gave it some different colors from red to blue. And what you overall see that secondary infections are not very common in COVID-19 cases, so it's more or less around 5%. If there are indeed infections, they tend to be coming quite late, and more sort of mirroring really hospital type of bacteria, and particularly in the ICU. So these are data from various countries, so varying from 3.5 to about 15%, but generally overall that the secondary infections are not that high, so it's not something to particularly worry about too much, so no particular reason to start too early. So what you see in the bacterial co-infections that they generally, which is quite unique as compared to influenza. So influenza, if you get a bacterial co-infection or superinfection, you think about Staph aureus, you think about pneumococcus, maybe beta hemolytic strep. But if you look at COVID-19, this is really more like a typical hospital-acquired infection, on the ICU in particular, coming quite late, generally also being gram-negative often, and also quite resistant. So really a hospital bug affecting the patients after admission. And this is also reflecting by the etiology, so what you find. So if you look at this is from New York City data. So if you look at overall the bacterial co-infections, generally the most are respiratory infections, quite some bloodstream infection and some both. And if you look at the etiology for respiratory, it's generally Staph aureus, Pseudomonas, Klebsiella, and Enterobacter and E. coli. So also here, really reflecting hospital bugs with being commonly resistant in 15%, and 5% even being carbapenem resistant. And if you look at the Staph aureus etiology data, also here Staph aureus, but also Staph epidermidis, and also Enterococcus, and here probably also reflecting more central line associated bloodstream infections, or CLABSIs. And you can imagine that these patients were also often on the ICU being taken care of by nurses coming from the ENT department or some other department, not particularly well-trained ICU nurses. I'll talk a little bit about that later. So you can imagine that also here the risk of CLABSIs and other hospital-acquired infection will increase in this group. So you see also here a reflection of nosocomial infections, and also here that 5% of the bloodstream isolates that were gram-negative were also carbapenem resistant. So what you can see here that also besides this, these patients have prolonged hospitalizations, often also readmissions or going to nursing homes, so potentially also causing spread to other patients later on in their patient trajectory. So it's not only about bacteria, so generally the focus of this talk is indeed bacteria, but as you probably heard maybe this morning from our dear colleague from India about fungal infection and invasive fungal infection. So in India, in this big network that it did in a recent study, that Candida auris was a really also very important cause of CLABSI, and one of the most common ones, and also with a very high mortality. So 61%, so this is really amazingly high on the COVID-19 ICU. So very scary indeed if this will broaden also to other countries. We have not seen this effect in the Netherlands, but something to really be aware about. So then some bit more data on antibiotic use than over time in Baltimore. So also here, actually what you see that in the dashed line is the COVID period, when COVID, the first cases start to come in. So you could see indeed an increase in the beginning, but also later on a decrease, particularly for early pneumonia, for example. So also here you see the learning effect, and not that the increase persisted over time. So what you've seen is that because of AMR, national action plans have been implemented across the globe, not always with a good budget, not always with very good activities. But this is a very nice study that actually Souha this morning made me aware of, and I decided to incorporate it. So that actually if you have high quality national action plans, and also high quality national action plans also of course reflect the people making the action plan. So it's not just having the action plan, it's also the whole sort of ecosystem that actually this action plan come from. But that you see that the countries that have very high quality national action plans, that actually if you have a very good action plan as compared to poor action plans, that the azithromycin use in COVID-19 actually was lower. So here again, get your act together if you don't have a good national action plan, because this really helps. But of course, it starts with good collaboration, as mentioned before. So what about IPC, so infection prevention and control? So it's always good to look what was the situation, and it's of course also to do with antibiotic use before the pandemic. So what was the infection control and prevention strategies across the globe? And so WHO has a certain strategy, a stepwise approach. So you can have like basic IPC levels to intermediate to advanced levels. If you want to know more about it, please have a look at the paper. And as you can expect that in the high-income countries, generally there's advanced levels of IPC, and low and middle-income countries, particularly in the low-income countries, this tends to be significantly lower. So you can imagine that because of COVID and people getting activities, actually can have a huge jump, and in a positive sense that actually there's going to be more attention to IPC, and of course also diagnostics later on. Because there was a lot of attention to IPC across the globe, from screening of patients, gowning, distancing, so there's hand alcohol, and this was being distributed across the globe. Of course, in the beginning of the pandemic, there were huge shortages because everybody was looking for the same stuff at the same time. But over time, we were able to get the production in order and get the distributions in order, and we were able to actually have along the trajectory of the COVID-19 pandemic that actually people were able to implement proper infection control practices really across the globe. But I didn't find really good data to show how, for instance, people were moving maybe from basic levels to more intermediate levels. And of course, here the focus is really on COVID-19. But what I do hope there's going to be a trickle-down effect that IPC is important. There's more attention also from hospital leadership to really invest in this. This is an example from Vienna in Austria in a hospital, how also the lockdowns and what was happening in the communities, how that really impacted also what was happening in the hospital. So there's really an interplay, and I also know, because I was responsible for the hospital infection control in the Netherlands, also for my own hospital, but we also wrote the guidelines for the Netherlands, that we were always looking at the epidemiology and what was happening in the community. and also to make sure that things that you advise in a hospital is not going to be really sort of countering what the government was saying, what needs to be done. So, because otherwise your messaging becomes really strange and not very effective. So ICU staffing, so this is something that everybody has experienced. So the nurses are, for me, really the true heroes during the pandemic. They're really always there at the front line, taking intensive care of these patients. You can imagine people in the ICU lying on their belly, being ventilated, because that was the best way to get them oxygenated. And it was really difficult in those cases, if the central line was in the inguinal area, to take good care of these central lines. It's even for an experienced nurse very problematic. And of course, that was one of the reasons that we saw a lot of central line associated bloodstream infections. And you can imagine also here that these infections will be resistant. But also, they had to learn a lot. So this is an example of they were creating all these tools for inexperienced people that, you know, if the oxygenation is getting very low, oh dear, you need to intubate. Here you really need help because this is not your competency. So a lot of these simple tools to help people that they experienced. So these are so hospital-acquired infections, really important. So this is really what did change on the ICU. So the CLABSIs really increased. We saw this also in the Netherlands. Also the potentially a little bit, but not as much, the urinary tract infection due to catheterization, and C. diff really, to me, didn't really make much of a difference. Then what about the AMR levels? So this is in the end what the talk is about. So generally it was 50-50 in the beginning, that people thought it either did or did not have a significant impact in a substantial way on AMR. So also here I will show you levels due to specifically in COVID-19 patients versus overall in a country after and during the pandemic. So I'll start with the bottom one, antibiotic resistance associated with COVID-19 pandemic, and this is a systematic review that was done. So this first author also wrote the other one I will show you later. And actually what you see here, that in the green box, this is actually all the arrows going down. So also here you see a lot of also decreases in antibiotic resistance for the various studies. And in the different columns, you have here MRSA, vancomycin resistance, Pseudomonas, Acinetobacter, ESBL, and carbapenem resistance. So carbapenem resistance, not that many arrows. But for instance, for MRSA, you see also a bit of arrows going down, interestingly. And if you look at the sort of systematic review and look at the incidence rates ratios, this is for the gram-positives, there's no significant change. This is just 1.0, and it didn't really matter the COVID-19 overall on the gram-positive. So this is Staph aureus, MRSA, and vancomycin-resistant Enterococcus. So for the gram-negatives, there's a tendency, but not significant, as you can see. So the confidence interval goes through 1. So here, interestingly, you don't see much of an impact. There is a trend. It's upward. You can imagine that this could be potentially the case, particularly in the ICU patients, that this would be the case. And particularly, this is the case if people did not have any stewardship or infection control practices in place. So on top, there is IPC and stewardship in place. So this is the first part. So here you see indeed a reduction, not significant reduction. And actually here, there's no mention or unknown, or there's nothing at all. So specifically mention IPC or ASP enhancement. And here, but I don't really find it very convincing, but here you do see a 1.11 risk ratio, and this is not going through 1. So there is a tendency that if you have nothing in place due to COVID, you can have an increase in your resistance in the gram-negatives. And if you look in the resistance levels, so now I'm going to the other paper, same author, same group, in patients with COVID-19, and this is also a systematic review, and maybe very difficult for you to read, but I will hopefully guide you through it. So particularly it's interesting to look at this middle box. So these are the infection people, so people who got a infection after 48 hours, a bacterial infection, and then you're looking at the resistance prevalence in hospital patients versus ICU patients, and you really see a huge jump, particularly in the ICU patients. And what you see that the resistance increases over time, so there's a rise in resistance later on in the pandemic, that the low-income countries, there is really a huge odds ratio of 10, that there's more resistance over there in the COVID-19 patients with resistance. And then something to reflect on later when you want to study it a bit more, there are some patient characteristics that may increase the risk or not due to AMR. So if you look at the Europeans, so of course I work and live currently in the Netherlands, and always looking at this data. So this is, just be aware that the resistance percentage, so this is from the European Center for Disease Control, so this is going from 13 to 16%. So you see a steady increase in third generation cephalosporin resistance over time. There's no delta at all in COVID, which was of course around this time. And then here for MRSA, there has been a decline already before COVID, and the decline continued. Maybe you see a little bit of less decline, but I don't think this will be significant, but that is maybe that the decline didn't go as fast as we would have hoped, potentially due to COVID. So this is another reflection, another way of showing the same things that I've mentioned before, and also sort of Souha, you see similar results in areas of war and conflict. So indeed, there are issues with resistance. For you, too little to see. And so here the resistance, and here is what is the antibiotic consumption in the COVID-19 patients. But the higher the prevalence, the more yellow it becomes. And you see that due to resistance, you see the most cases happening in the low and middle income countries, and less so in the high income countries. So this is another way of looking at it. So this is how, generally within COVID, if a patient uses an antibiotic, do you have a higher risk of an antibiotic-resistant bug later on? And indeed, this was the case, but generally this will be true overall for any patient being admitted for a longer time who's getting an antibiotic, and later on, will you find a resistant bug? This can be for any kind of reason or indication that people would get an antibiotic, not just COVID-19, and that probably the attributable sort of contribution to this was 17%. So not important, important to know, and this is particularly the case for the gram negatives also here, and not for the gram positive. So diagnostics, another important thing. So and this is always a slide I show if I talk about diagnostics. So generally, infection control, stewardship is going to be meaningless if you don't have medical microbiology or your diagnostics in place. Otherwise, you're just driving in the dark without your lights on. And I think COVID-19, despite, it was very detrimental for many people, but it did lead to a huge diagnostic advancement, more rapid diagnostics, also more interest in diagnostics. Just like IPC, also diagnostics had an advantage because of COVID-19, so huge developments. Companies before making washing machines, now making diagnostics. I mean, this was really happening also in the Netherlands. The canal boat tour guides, they were also suddenly testing people in Amsterdam. So a lot of new people on the block, new kids on the block. And it was quite amazing to see. So this was also by the Rotterdam group. So the sequencing was done in Asia very quickly. A PCR was developed by Charité and Marion Koopmans in the Netherlands. And this was in the Eurosurveillance. And this led to actually the PCRs that were being rolled out across the world. I was using that protocol. And later on, antigen testing came and more people doing testing at home by themselves. And the places where the most advancements were made regarding diagnostics was particularly Asia, less so US and Europe, but not so much in Africa and other regions in the world. So Asia was a huge driver and engine behind also diagnostic development. And also here, so Robin Patel speaking. So here now you see even the biofire, the panel. It's including resistant genes for pneumonia, but it also includes the coronavirus. So really looking at patients more in a holistic way. So all these things are happening right now, looking at things also more in a cohesive and coherent way. So to start to conclude, so pandemic indeed had a large impact on antibiotic use. Overall, actually, it was downwards in COVID patients, it was upwards, particularly in the beginning of the pandemic. Later on, people got better, particularly those countries with high-quality national action plans. Pandemic had also a large impact on IPC, so actually more IPC, but shifts in nurse staffing. So people not used to work in ICU suddenly working there, so less experience, so more hospital-acquired infection, thinking about central line-associated bloodstream infections, for example. Pandemic also had a huge impact on healthcare seeking behavior, so more telemedicine, but also less surgeries potentially, so also less hospital-acquired infections in that particular group. But unfortunately, besides we had a vaccine very fast, there's also, unfortunately, due to COVID, a lot of mis and disinformation. We're still having trouble with that still now today. This is leading to people not taking vaccines. So this will have a huge impact on vaccine-preventable disease and measles and related infections due to measles, and also people seeking more healthcare. But also a large impact on rapid diagnostics. So overall, indeed, the pandemic had impact on AMR, but differs by region and moment. So lessons are that there are a lot of innovations being done that we can leverage from. Drugs, vaccines, diagnostics, IPC, but also just overall resilience and being flexible and creative, working together. Access to diagnostics is crucial. So I didn't talk about it, but biomarkers, how can it help to decide to take an antibiotic or not? The speed, so more diagnostics closer to the patient. But also a lot of easy tools, like for nurses, certainly working in ICU, to help them. And then reliable data is still needed. So besides war, also during the pandemic, particularly for these kinds of things, it was very difficult to get good and reliable data, a lot of bias, but lots of potential for the future. So I'm very hopeful, and I think overall the AMR, due to the pandemic, is not as dramatic as some may think. And then if there were problems with AMR after the pandemic, generally these places already had a problem before. So we don't know if they would have been rising to the same spot and the same AMR level without the pandemic. So I think that is the main problem, and getting a good national action plan and people working together is the main thing that people need to do, rather than blaming the pandemic itself. Over. And then, of course, I welcome you in Manila as well, like Souha and Regina.
Thank you very much, Dr. Wertheim, for an excellent presentation. I think we have time for one question, but for sure, one of the very few advantages of the COVID-19 pandemic is that it elevated the role of infectious diseases practitioners and infection control practitioners. So people gave more value to our profession in the respective countries. Time for one question. If no question, okay, no question. Just a very quick question for me, a quick answer because we have 20 seconds. We saw a decrease in AMR in my country, but we saw a rise in Stenotrophomonas, maltophilia, and VRE. Any ideas why would that happen?
Yeah, I mean, that's partially probably in a particular group of patients admitted potentially for a long time. And of course, I mean, Stenotrophomonas is very resistant, so if they get broad spectrum, you will select these unfortunate drugs that are more difficult to treat. And often they can reflect also colonization. The question is it really infection or colonization? But yeah, that's potentially a consequence of maybe too much antibiotics and too broad spectrum. And not optimal IPC.
Okay, so let's go to the third topic in this symposium. So we moved from AMR in conflict zones and then AMR post-pandemic. Let's now listen to a talk on antimicrobial resistance among clinically significant bacteria in wildlife, an overlooked One Health concern. So I have the distinct pleasure of introducing our speaker, Professor Geoffrey Coombs. is chair of the public health at Murdoch University in Australia. He's also a very prolific researcher with over 260 peer-reviewed scientific papers and over 400 national and international conference publications. He's ranked by Scholar GPS in the top 0.5% of all scholars worldwide. Importantly, he is the past president of the International Society of Antimicrobial Chemotherapy. So everyone, let's please welcome Professor Geoffrey Coombs.
Thank you all. Thank you for that very nice intro. So I'm taking it to a different place now, talking at AMR in wildlife. And so the question that I've been given is it a One Health concern? Okay. So very different from the COVID talk and the previous talk by Souha. I have no disclosures to declare, but I would like to thank the organisers of the meeting for inviting me to come and giving this talk today. So, One Health. So what is One Health? And I'm sure most of you are aware of, have heard the term before, but basically what it does, it connects or it links together the health of humans, all animals, that's domestic and wild animals, plants and the ecosystem. And what it does is by doing that, we are able to talk about sort of major infectious disease problems. We talk about food and safety, emerging infectious diseases, and probably most of you are aware with infectious diseases, about 60% of infectious diseases that are known as a result of transmission from animals to humans, and about 70% of emerging infectious diseases are the same, this transmission from animals to humans, and also climate change, and more importantly, also antimicrobial resistance. And so what's the aim of One Health? Basically is to achieve really, really good, excellent and ongoing health outcomes for people, animals and ecosystems. So that's One Health. So sorry, I've just gone back. Okay. So my next question is, AMR a One Health concern? And I don't think that's anything to tell this audience. AMR is considered a greatest global threat to human health. But when we look at the UN, and it looks at on a larger picture than human health, and looks at more of a One Health situation, and they have huge concerns that in actual fact antimicrobial resistance has a threat to the achievements of many of the United Nations SDGs. And that's because AMR has no boundaries, it has no species boundaries or as far as geography boundaries, and AMR can spread between humans and animals and plants and environment. So with the United Nations, yes, certainly AMR is a One Health concern. And that's been shown in 2015, I'm sure you're all aware of this, when it came out with its GAP plan. And you can see the major theme or the idea of the 2015 was providing an understanding of how AMR spreads and its relationship between AMR and antimicrobial use in humans and the animals and the environment. And in 2023, it strengthened the One Health side of things by having more of a One Health approach to its research agenda, which promoted a One Health approach to AMR, research to improve human, animal, plant, environmental health, and promote growth at national, regional, and global levels. So if we look at the United Nations and looking at antimicrobial resistance, certainly animals play a role in resistance. And with animals, we can divide animals in sort of three areas. There's the domestic animals, we have pets. And as far as pets go, your cats and dogs, you basically give them an antimicrobial resistant organism, whether an MRSA. If you have an MRSA, it'll carry it on to the dog. The other class of animals is the livestock industry, and this is a huge concern as far as antimicrobial resistance, because in the livestock, unlike in domestic animals, antimicrobial resistant bacteria can actually emerge. And there's been many examples of this. The one that I give here is the one, because I do a lot of work on MRSA, is this one here that was first reported in Europe. And it's now throughout the world. And this was an ST398 MRSA, in particular MSSA, which is very common in humans, that went from humans into pigs. And the pigs, it's intensive farming, there's a lot of antibiotics used. And as a result of that, an MRSA emerged, and then that went back into humans. So obviously livestock play an important role. When it comes to wildlife, it's not so clear. Certainly over the last number of years, more and more is being published about the presence of antimicrobial resistance in wildlife. And this is a really good review that I can refer to in 2024, which shows the number of publications have increased dramatically. But because none of the national action plans, in actual fact, have included surveillance of antimicrobial resistance in wildlife, we really have no idea how bad or good the problem is. So AMR in wildlife. We wrote a review, one of my PhD students did, Zing wrote a review that was published in 2024. We looked at all that had been published on antimicrobial resistance in wildlife from 1978 to 2023. And she found 221 journals from 68 countries. And it varied the number of publications per country. The highest was in Italy. They had 21 publications. But you can see in the grey a number of countries that have not published on antimicrobial resistance in wildlife, and a number of the papers that we used were single publications only. So I'm going to concentrate on two bacteria. First one is MRSA. And so you can see in MRSA in Europe, in wildlife, there's been a number of papers have been published. And it ranges from MRSA from 1 to 66% in wildlife. And most of that wildlife is in hedgehogs. And that's interesting, and I'm going to come back to that. That's an interesting story. But we certainly find it in hedgehogs in other countries outside of Europe, New Zealand, and we find it also in other animals, such as in magpies and vultures. In Spain, in Portugal, we have the wild rodents and wild boars. So MRSA is evident, has been found in wildlife. And same with ESBL-MC. This is mainly in birds, but it's found in a number of countries. And it ranges in birds, it ranges from 1.7% in Switzerland to 54% in Chile. And it's found in other animals as well, from 5.2% Peru to 22.2% in Japan in wild mammals, and also found rarely, or occasionally in reptiles at 5.6%. And so we looked at what were the antimicrobial resistance genes that are important to health that have been published. And certainly all of the antimicrobial resistance genes that we consider important have been found in wild animals. And this includes the ESBL-MC, which was reported in 36 countries. The number of the size, the number of reports that are reported, the larger the circle, so up to five papers. So I must say, all of this is not surveillance. This is just sort of ad hoc reporting. We have no idea what the true picture is. But there have been 36 countries that reported ESBL-MC throughout the world. CREs in 12 countries. We've had MCR reported in wildlife in 16 countries. The MEC in MRSA in 12 countries, and the VAN gene in 6 countries. So this is an interesting diagram that we concluded our review on. We're sort of connecting antimicrobial resistance with the different animal groups. And you can see with wild birds, MCR and SBLs is quite common, but they also have CREs. In the mammals, we have CRSE. The VAN-A is more into the wild birds. And overall, reptiles don't have a lot of antimicrobial resistance genes. And the MEC gene is found in wild mammals. Okay, so I've told you that wildlife have antimicrobial resistance genes, and so how do they acquire it? How does an animal in the wild acquire antimicrobial resistance genes? And this is actually interesting because in livestock, it's quite common to have antimicrobial resistance genes, particularly in the pig industry and those intensive farming industries. And that's not surprising because about 73% of the antimicrobials that we use each year is actual fact used in livestock. So obviously antimicrobials is driving antimicrobial resistance. But antimicrobials are rarely used in wildlife. So what's driving this resistance? So putting aside intrinsic resistance, okay, so that resistance that occurs naturally, does antimicrobial resistance emerge in wildlife? It's kind of rare, really, and one of the few examples that we have is the hedgehog. So that goes back to that diagram I had with the hedgehog, and in Europe, a lot of hedgehogs, particularly in the United Kingdom, have MRSA. And this is quite an interesting story, really, because they harbour a fungus, a trichophyton, which produces two antibodies. And so for the Staph aureus to survive, it's a selective pressure. In actual fact, it acquires the MEC gene and it becomes MRSA. This is even a further interesting story. In actual fact, this is probably where the first MRSAs came from the hedgehog. Not that I dislike hedgehogs, but it's probably what it is. But this is really unusual. Antimicrobial resistance doesn't emerge in wildlife, not that we know of anyway with the studies that have been done. And it's more really antimicrobial resistance in wildlife is as a result of interactions with human beings or with human life. And it's a complicated pathway, like most of the pathways. So how does wildlife end up getting antimicrobial resistant bacteria? And so it's their exposure to animals and humans that have been obviously exposed to antibiotics. And this comes through contaminated food, water and waste, pesticide, fertilizers, etc. in the environment. Okay, so there are three major ways that wildlife can acquire antimicrobial resistance. The first is the interaction with humans. Okay, and so we have a number of wildlife that are very close living with us in our urban environments, and they feed on human waste and interact with human feces and sewage system in urban environments. And therefore, they can easily acquire these antimicrobial resistant bacteria. And we see with wild birds, they're often colonised by antimicrobial resistant bacteria because they're eating food. And the seagull is a classical example. There's been a lot of papers on seagulls looking at who've acquired antimicrobial resistance. And those seagulls or birds or wildlife that are close to human environment, their antimicrobial resistance genes in their faeces is much higher than those, or similar to those that were bird life, such as poultry or even livestock that are fed antibiotics. And seabirds such as gulls are very close to the coastal area. They, again, close contact with humans. They carry E. coli clones that extensively overlap with the human clinical E. coli. So that's sort of the major reason why wildlife would have antimicrobial resistance bacteria. But it's also those on the farm. So those have close to agricultural area. And we know on the farms there's a lot of fertilizers used, there's a lot of antibiotics, etc. And the studies that have been done on animals that are quite close to farms have shown with their E. coli's, there's a much greater chance they'll have antimicrobial resistant genes than those from the same animal class that don't have a close contact with the farm. So livestock interactions may also increase the risk of AMR dissemination. The third way wildlife can acquire antimicrobial resistance is through the antimicrobials used in the human and veterinary medicine are excreted into rivers and lakes and soils. Okay, so these antimicrobial resistance genes do last for a long time, and so the wildlife are exposed to them. And there's been lots of studies looking at this, where coastal free living mammals such as mice and voles and shrews are more than twice as likely to harbour AMR E. coli compared with non-coastal mammals. So really, if wildlife has an antimicrobial resistant bacteria, it's basically human pollution. It is rare that it emerges in wildlife. I mean, I gave the example of the hedgehog, but that's a very unusual circumstances. So it's normally because it's become in contact with human or farming pollution. So I've told you that antimicrobial resistance does occur in wildlife. I've told you that it acquires it, but does it transmit it? So transmission of AMR. Like most pathways, it's quite complicated. So although wildlife doesn't have a fundamental role in the emergence of AMR, it may have an important role for AMR transmission. And once the antimicrobial resistant bacteria have been acquired by a wildlife host, they can be transmitted to other environments, including humans, transported through different areas, and therefore they can spread AMR locally and worldwide. So while this slide here is sort of quite complicated, there's just really two ways. There's what's called short distance, and that's the One Health issue, and there's long distance, which is the global health issue. So what do I mean by One Health and global health? So One Health is when it's all interconnected. So you've got the hospitals, the water bodies, the foods, the pets, or the farms, and they may have on the emergent dissemination of AMR. But then you have the global issue, and that's where studies have shown that the emergence of AMR in one region, one country, one continent can impact other regions worldwide. So I'll give you two examples. I mean, there's lots of examples, but I'll give you two examples of one of a local, so One Health, one of a global issue. So the local, two examples I've shown, rats and bats. And so wildlife may closely share the same environment as humans. And so we know that rats, they carry antimicrobial resistance genes in their gut that are frequently found in human bacteria, okay? And for example, for ESBLs. And these rat feces, they eventually present on phytomites, which can be a source of transmission of antimicrobial resistance genes and antimicrobial resistant bacteria. And there was an interesting study that was done on this particular rat. The rat is Novagicus. I'm not a rat expert, so a rat. And this rat is often found in hospitals. And they looked at the rat, and it was carrying vancomycin resistance genes that were linked to the transposon TN1549. And so, more importantly, also these rats or mice or fleas have been shown to be models of antimicrobial resistance genes, and they very efficiently transfer these genes from one animal or the same species or other species quite easily. So that's probably an important cause of transmission. Another example I give is with bats. And bats, they feed on live farm animals that carry E. coli belonging to the most prevalent sequence types causing infections worldwide, as well as several of the ESBLs are concerned in hospitals. So these animals, they can transmit quite easily. That's on a One Health. So globally, I think we go back to the bird situation. And so we know with seagulls, so as the picture here describes, they feed on human rubbish and etc. So, and quite often they'll carry clones of antimicrobial resistant bacteria and have antimicrobial resistance genes that are prevalent in the hospitals. And they're located on the same plasmids. And there's been tracking of the gulls to show that they can spread these from one country to the other. So this is an example of global health. Okay, so back to the question, is antimicrobial resistance in wildlife for public health? I've shown you that the antimicrobial resistance is present in wildlife. I've shown you how it acquires it and how it can possibly transmit it. So is it important? Okay, is it a public health concern? Well, it's an interesting question, really. So although wildlife has the potential to maintain and spread AMR across landscapes and geographic regions, we really don't know if we have this spillback, when in actual fact from wildlife to humans, it actually does occur. So it's really poorly understood. And the other thing is that even though all these organisations such as World Health, FAO and IE have said in your national action plans you should include surveillance of wildlife, the reality is no one is doing it, from what I can understand looking at publications. There's sort of ad hoc surveillance is done, but no one includes surveillance in their national action plan. So basically, it's unknown. I really can't give you an answer. Is AMR wildlife a public health concern? But what I can do is tell you the gaps. Let's look at the gaps. What should we be doing to try to answer this question? So we should be asking ourselves how AMR moves between wildlife, the environment, food and humans. We know AMR is there, but we have no idea how it moves. How important is the importance of wildlife in the maintenance and dispersal of AMR? The extent of AMR within the free-ranging wildlife animals. Should we be doing surveillance? Is it cost effective to do surveillance? And how should it be focused? The usage of antimicrobials in the treatment of wildlife. In Australia, I don't know, other countries, we have these wildlife hospitals where, so the wildlife, if they're injured, they come into hospitals. So I think that would be a really important start for doing surveillance in that situation. And finally, the potential impact of AMR on the health of wildlife species. And so with that, I would like to thank my PhD students, particularly Zing, who's circled here, who wrote the review, and my postdoc. And I also would like to thank all those, welcome all those to the ICC meeting. Thank you.
Thank you very much, Dr. Coombs. This was an excellent overview on a difficult topic because, as you have very well outlined, not a lot of published data. We have 5 minutes, so we can take a few questions from the audience. Okay, I know Heiman is very passionate about this topic of One Health and AMR, so we give him the first question.
Love-hate relationship with One Health and AMR, but regarding wildlife, it's just representing what humans are doing. So it's very anthropocentric and just reflects what's happening in humans, and the humans are the main driving force. And probably you'll have some spillback here and there, but in the end, it's really about controlling it, the humans. And if you're going to put resources in wildlife, where do you look? If you find something, what do you do? I think it will lead to some crazy stuff happening, which is not going to be rational. So I would really advise not to do anything and leave the wildlife alone.
I agree. Reading all the publications, I kind of agree with that. But I guess until we know a little bit more, as I outlined, in the knowledge gaps, I guess we can't quickly come to that conclusion. So, yeah. So.
Any other questions for Dr. Coombs? Perhaps I have a question. Is there a role for the migrating birds? And we keep hearing about the effect of global warming on AMR. How can we fit in the wildlife colonization with the global warming? And can you think of any link?
Yeah, the global warming, sorry, no, I can't. I'm not a global warming expert, so I can't think of that offhand. But certainly the birds is a big issue. I mean, and we've shown that with seagulls, particularly. There's been a lot of work done on birds, and it's been shown to be spread antimicrobial resistance from one continent to another, let alone one country to the other. So yeah, the birds should play a major role. As far as climate change, I don't know about birds and migrating and climate change, so I can't answer that.
I think there was a question from the audience to the first presentation, which we didn't have time because I took most of my time. If you are still interested in asking the question, please go ahead. We still have 3 minutes.
Sorry.
That's okay.
So my name is Yuan. I'm from Australia. My question was around, we all know the impact of global funding cuts in terms of aid and things like that. So what can we do, or what is being done to counter the impact of the funding cuts in terms of, training of lab personnel in these conflict zones, as well as maintaining WASH practices and all those basic public health issues?
Yes, I think this is a very important question and very tough to answer. I think with the cuts on funding for research, particularly that are affecting low-middle income countries, whether they are in conflict or non-conflict, I don't think a lot is being done currently. A lot of the research is relying on donations, which I don't think is the way to continue. The big organizations that help funding important research in such settings have cut back significantly. So I don't know if Dr. Coombs or Dr. Wertheim or Dr. Berba, do you have any thoughts about or any ideas about what is being currently done to attract funding to keep on doing the work? I think except for MSF, we've really not seen any organizations putting money in those conflict areas.
For Ukraine is European Union.
Yeah.
And also
Yeah. I mean, unfortunately, for Ukraine, Europe got together and funded work for Ukraine. Unfortunately, I can't say the same about the Arab countries. And as you know, for the Arab countries, you have some very, very rich countries and some very, very poor countries. So you have the two extremes within the same Arab League. But we've really not seen a collaboration where the rich countries have really moved forward to fund work and research and implementation in the poor countries, if you want to call them. Now, some of this might be political because, as you know, this is a very polarized region. The Arab, I don't want to be very political here, but this is a region that's very polarized politically. And unfortunately, we've not seen the rich countries coming forward to help. All right, I think we're going to go with concluding remarks from Dr. Berba.
So I'd like to close the session. This was a very fruitful discussion on various challenges in AMR, which we see in different scenarios. Thank you to the International Society for Antimicrobial Chemotherapy, Professor Souha, President of ISAC, Professor Heiman, President-elect of ISAC, and Professor Geoffrey, who's the past president of the ISAC. So we'd like to thank you all, and let's give them a big hand again for this symposium. And I'd like to invite everybody again to the next International Congress of Antimicrobial Chemotherapy, which will be on 2026, December 7 to 9. Please save the date. That will be in Manila, in the Philippines. So we'll see you there. Thank you very much, everyone.